So hi everyone, my name's Rachel Moses. I'm a consultant respiratory physiotherapist and I'm also working in a chief allied health professional role at the moment. And I'm delighted to be joined by my good friend and colleague, David McWilliams, who is officially a consultant physiotherapist in critical care at the University Hospitals Birmingham and is also chair of the physiotherapy working group for the European Society of Intensive Care Medicine. So welcome, David.
Thank you. Thanks for having me. Good to be here.
So for any of you that have listened to other short series podcasts we've been doing around COVID-19, we very quickly put together some lived experiences of clinicians, particularly physios, who've been working in the clinical and non-clinical environments around COVID. The disclaimer is that this is individuals' perceptions, this is individuals' lived experiences. We're not saying it's right or wrong. And the reason why I'm having a one-to-one with David in particular is not just because he's an all-round legend and role model for us respiratory physios, which you'll absolutely be cringing inside of us saying that, first of all. It's because he, in his trust, have had treated an incredible amount of patients, over 200 intubated COVID patients within his trust. And David is the lead physio there. So we're having a separate podcast around a team of ICU physios, but really I just wanted a bit of one-to-one time with David in his role and what he's experienced. So I'm really grateful, David, as you know. So if I just want to start by asking how your ICU adapted, if you think back to the early stages when we started to know this pandemic was going to hit the UK and our intensive care units, how did your intensive care unit adapt to meet the increased capacity needs of COVID?
So I think we were really lucky here in terms of our kind of senior management team for ICU created a specific COVID-19 tactical group. And they seem very ahead of the curve in terms of a lot of plans were in place before this had even started to hit within the UK and within the critical care community, almost to the point where it felt, was this too much too soon? But what they did, they looked at creating a specific stage surge plan. So some people probably know we have a 100-bedded critical care unit here at the QE, which was open to about 75 beds at the time that all this was hitting. And basically we created a surge plan that could take that well over 200 towards 250 or even more ventilated patients at any one time. And linked with this was looking at various different sections of the critical care team and how this could be managed. So we had models which initially started with your standard one-to-one nursing, but could actually flex up to one critical care nurse to 4 patients, with the other 3 really being supported by theatre nurses, non-specialist critical care staff, or even some redeployed staff from other areas. And to do this, they basically created or went towards a task-based nursing role. So we ended up with teams, sub-teams responsible for different things. So we created a proning team, a lines team, a tracheostomy team, to make sure everything was really in place to maximize the experience on the unit, but also to prepare the other staff to support as much as possible. And then that really translated and factored over into physiotherapy as well, where we had our kind of normal staffing ratios, but creating more of a stepped surge plan to meet the increasing demand.
That is phenomenal. And it almost sounds, thinking back to me military days, like how, and there's been lots of correlations across military and NHS, but it's that level and detail of planning involving an organisation as a whole that maybe we've never fully experienced, certainly in my career in the NHS before on this level. So it's about that whole system approach, about how you stage your response as well. So it's not everything straight away, it's not making every single change immediately, but actually what you found in your organisation, and I remember speaking to you a few weeks ago, and you had maybe 10, 20 patients, didn't you, intubate, and then in a very small period of time, you surged to maybe, near on the 100 mark. So do you want to, in terms of having a little bit of time, you weren't far behind London actually with your surge, if I remember rightly. The rest of the nation kind of had a bit more time and were learning from the centres like yourself and in London. So tell us a little bit about how the surge planning you anticipated and then the reality of having to do it in a short period of time.
Yeah, so what we basically did right at the start was empty one of the sections of our critical care ready to take these COVID admissions. And I remember sitting, thinking there were no patients coming through, and then it started with just 1 or 2 patients at a time being screened, coming back negative and being moved on, and really thinking, is this really going to hit? Is this really going to be as big as a case as it was? And we did then start to get just the first couple, as you mentioned. And it was really nice at that stage in the response, because we could practice things like the donning and doffing. We could get established the pathways. It started to identify some teething issues, like we were doing the donning and doffing, but there weren't people around to empty bins, just logistical issues. And everything was surging quite nicely, and I was developing kind of staffing plans to match with that. And it was a few patients coming in each day. And then I remember it was, I think, across a weekend where we were just becoming aware that some of the local hospitals were starting to fill their capacity quite quickly, having smaller units. That was happening a lot earlier. And we were then going to start getting some diversions from other trusts. And it was literally a case of, I came in on the Monday and we had 19 ventilated patients. And within 7 days, we went up to 90. So we were getting between 10 and 12 admissions every day. And every plan that I had in place was almost out of the window, and we just had to jump to the final stage and bring as many people in as possible. So we reworked physio rotas, we reworked staffing plans to get people doing long days to get this coverage in. And it was almost, we thought we had time, even though a short space of time, and even that wasn't enough. So it was very rushed, but very effective.
No, so you've kind of moved on to the next thought in my head of the question is, how do you even start to prepare a workforce? So we've had a separate podcast with the leaders and managers who have explained their lived experiences, but we are massively under-resourced, even in the best intensive care units in the country, in terms of not just physios, speeches, dietitians, OT, psychologists, you know, all of the allied health professionals. So where did you even start to prepare a workforce that maybe didn't exist, 2 months ago, to work in your critical care and to deal with these over 200 patients?
Yeah, so we, quite early on as part of the tactical group, we almost had a notion of, let's just plan that there will be 2 points of business in this hospital moving forwards. One will be ventilated patients within critical care. The other will be these patients recovering on the wards and non-acute admissions. So we sat down very early with our physio management team and our AHP management team and went through the entire physiotherapy workforce and allocated into one of those 2 roles. We also did department-wide training on ARDS, because a lot of people on the, maybe had just started in the trust, maybe on the outpatient rota, needed some skilling up in those areas. So ARDS, the specific impact of the coronavirus and COVID-19, and then optimizing secretion clearance in these kind of significantly unwell ventilated patients. So we ran daily training sessions, socially distanced, of course, the more than 20 patients, 20 physios at once. And we managed to get pretty much the entire department through in this planning stage, starting that early, and then really allocating who was working in the staffing for that week, who were the next tier that we could pull on if things started to escalate. And we had kind of a 3-step plan again of where we could pull people from very quickly at very short notice, which really helped as things surged.
No, that's amazing. And I think just a little plug here for leadership posts, because this is where I think the leadership posts, the consultant HP posts really come into their own, because you've been in that role. That was a role specifically designed, if I remember back, to lead the critical care and physiotherapy team in Birmingham as they increase capacity. And here you are today, you know, displaying and describing beautifully about the impact of having someone in that leadership role that could bring everyone together with the managers. And I think some of the trusts that have really struggled, who I know will be listening to this podcast, is having that person who has the knowledge, the insight, the skills, the abilities to transform a workforce within what is a matter of days, not weeks, to meet a change in capacity for very, very complex patients. So massive plug there. So you have this workforce, and now you have the patients, and you don't just have a few patients, you have a lot of patients. And we are hearing about the very specific challenges that COVID patients have in terms of critical care. So do you want to, in your own words, just describe some of the common problems that patients with COVID-19 had in the intensive care unit that you've seen? There's very different phenotypes of these patients as well, we'll have to add at this point, but what you specifically seen in this patient group.
Yeah. So I think what was most interesting is probably what we were expecting to what actually happened in practice. So I think there were lots of reports coming out to kind of suggest that these patients were non-productive. It was a dry ARDS. They were unstable, almost more of a hands-off approach. There were lots of lines around protecting staff and making sure, yes, you've got the adequate PPE, but don't go into a bed space if you don't need to, don't expose yourself. So at the beginning, we probably went along these lines of ward rounds with the consultants to identify who maybe had a secretion issue, who would need physiotherapy intervention, and moving forwards from there. And what became very apparent within just a couple of days is there was quite a big secretion load in the majority of these patients. And if they didn't come in with that secretion load, generally 3, 4, 5 days after that admission, they were starting to get instances of plugging off. A lot of these patients were being proned, and we were having real issues with getting them back into supine, again with thick, sticky secretions and instability. So I think the secretion load was one of the biggest surprises, but actually meant we had quite a lot of input to get involved with these patients, and the ward rounds turned into, I want you to see everybody. It did maybe modify the way that we were assessing people, again with the full PPE. Some staff wearing hoods meant things like auscultation weren't possible. So we were using other techniques such as putting our hands on people's chests and passive autogenic drainage, ventilator waveform analysis to try and inform our thinking. A lot of these patients are then prone, paralyzed, which meant they became two-person techniques, manual techniques, assisted coughs or compression of ribs to try and maximize peak expiratory flow. So at least 2 physios. So even though we then said, okay, we had 100 ventilated patients, that was almost like having 200 because they were all doubles. One of the other things that I found quite surprising was just the high amounts of sedation these patients were needing. So a lot of them seemed agitated, a lot of them with no history of any substance abuse or alcohol history, for example, were needing really high doses of sedation, with a lot of ventilator asynchrony, a lot of instability on that side as well, which led to, I think we've just done an analysis, around 92% of them were paralyzed for a good portion of time. And that again brings its own challenges. We found kind of a transient hypoxia. So even just rolling or repositioning patients, they seemed to desaturate very quickly, and that took a long time to pick back up. And it meant that as we were treating these patients, almost universally, there seemed to be an initial deterioration in their function, although later they did improve. But that in itself was challenging for staff coming into the intensive care, perhaps not as confident and not as experienced, who are seeing patients deteriorate in front of them. So really challenging the highest level of clinical reasoning, even in our most experienced staff as such. So very challenging from a respiratory point of view, which perhaps we expected. Really difficult sedation issues and ventilatory issues, and a really high secretion load was probably some of the biggest things that we saw.
Absolutely, and certainly that mirrors some of our experience. And we've also had a MDT ICU podcast where it involved the huge nutritional challenges that existed with these patients, the airway pathologies we were seeing that we never ever anticipated, and how that impacted on weaning. But just to pick up on a couple of things you've mentioned there, sedation and paralysis, I think across the networks when we've been having these kind of chats that haven't necessarily been recorded, or you're absolutely right, these patients needed sedation, a lot of sedation, and paralysis, which means they can't cough, in the normal mucociliary escalators that you rely on to mobilize secretions with certain techniques that we might use, didn't exist anymore. That combined with us initially, and I'm looking for your experience here, not using any water humidification and just relying on HMAs and viral HMAs and viral filters. And do we put double filters in the inspiratory limbs of these circuits, and in a filter in the expiratory limb? And it's the challenges that existed with actually delivering ventilation in the first place, then added on top ventilator supply problems where we're using anesthetic machines, maybe if we don't have enough intensive care ventilators. So in terms of your experience of using water humidification, there's 2 questions. Did you use it? And at what stage did you use it? And do you have a rule that everybody kind of should be given it if you've got enough humidifiers?
Okay, so probably the slight disclaimer here is the position of the trust prior to all of this starting, which is that it's a HME-based unit. We're one of those trusts that, from a consultant body, aren't big fans of heated humidification, and tend to see that the negatives outweigh any positives. That's a trust position. I'm going to make any specific comment today. So universally for these patients, they were managed with HMEs. Further down into I think some of that again were concerns around aerosol generating by adding in the humidifiers. And I think there were real concerns about that and how that would be managed. In terms of protection there, I'm sure what most trusts did when things like when patients were proned, we were clamping ET tubes, any disconnections to change to put nebs in the circuit, for example, again, ET tubes are being clamped. But yeah, we had a very HME-based humidification system. To combat it in other ways, we started carbocysteines and mucolytics from day of admission. We knew secretions were issued and we knew there were going to be a problem, so we took a proactive stance on that point. We used a lot of instilled saline, which I know is controversial, but my own opinion works very well in practice, especially when combined with manual techniques and repositioning and assisted coughs, which is how we kind of managed the majority of these patients, both in prone and in supine. We did use some heated humidification towards the end of the kind of surge period, really, when we had some of the longer stay weaner patients, but it was quite rare in practice.
Okay, and so we are hearing this in terms of HME would still be the go-to method of humidification for COVID patients. And again, we're not generalising here or saying this is what we're doing in the UK, this is just our experiences. But in terms of tube blockages, did you have a lot of tube blockages, or maybe was it because you were actively, engagingly starting patients on mucolytics? So we know that carbocysteine has a little bit of a threshold effect, and that it takes a few days actually to have a benefit. Using lots of saline, which I do have to agree with you here, has been hugely beneficial, not just for airway clearance but for tube patency in my experience, combined with active physiotherapy, hands-on physiotherapy. So did you have a lot of tube blockages, and if not, do you think it's because of everything you've just described?
I think anecdotally at the start, I think we had a couple of not total blockages but near blockages. We perhaps had one or two instances of tubes blocking overnight when we weren't around. I think once we took a more proactive approach with the carbocysteine and the kind of slightly more consistent physiotherapy for these patients, it seemed to decrease quite significantly. So I think it was well managed without the heated humidifier, but yeah, certainly less blockages then.
Well, if that's not a point in itself, the fact that you guys, in your experience in Birmingham, you maybe didn't have the same type of airway or airway blockage incidents that some trusts had, and you have an incredible physiotherapy team there who have got great skills in terms of manual techniques. I think I just need to throw that in there. So moving on to some of the common treatment interventions now, you've spoke a little bit about the hands-on type of stuff that you did and positioning. Can you just say, if I can paint the picture a little bit with a patient who with COVID-19 who has been ventilated for maybe a week, who isn't being proned anymore, so they've got their oxygen levels are stable, but they're still paralysed and sedated, and they have a secretion load problem, and obviously have no cough. How might you have treated that patient?
So what I've always taught my staff is that we look at treatment as kind of an escalator. When you start in the bare minimum, then add layers as you go through. So start with your suction to assess. Is there a cough effort? What are the secretions like? Are they thick? Are they tenacious? Now, with the paralysed patient, obviously all you're doing with your suction to assess is cleaning the ET tube at best. But actually with these patients as well, it's trying to make those decisions in line with that person's stability. And you may only have enough stability for one or two rounds of intervention. So we probably went in a little bit higher. This type of patient, if we knew there was a high secretion load, or we knew there were particularly thick, sticky secretions previously and reported by the nursing staff, we would instill some saline, do an assisted cough, and almost do an assisted cough suction to assess. If we knew from X-ray or from palpation that there was a specific one-sided issue, again, based on how stable these patients were on repositioning, instill saline inside lying, reposition to the opposite side, manual techniques to try and loosen, and then a expiratory compression to increase peak expiratory flow with a deep suction. That tended to work very, very well. We avoided MHI, as was the recommendation, and that would be kind of the ideal option really with patients with severe ARDS or lung restrictive lungs. VHI we did use on occasion, but I have to say the thing that struck me, didn't mention this earlier with the COVID-19 patients, where often with the manual techniques, they almost seem to present with quite compliant chests. So you would compress the chest and you'd get really big volumes back in return. Whereas perhaps some of the severe ARDSs I've treated in the past have needed really high peak pressures, really stiff lungs, really stiff chest to try and generate any sort of volume. So with the manual techniques, we might be doubling tidal volumes anyway, which was definitely helping to shift things. If we had somebody in prone, and I know you said this person wasn't being proned anymore, we were finding really good success with instilling saline with the bed tilted as it would be for these patients, and then going to flat or even head down, and then doing manual techniques with this assisted cough, so to speak, which again was working really, really nicely.
Absolutely. And I think you've hit the nail on the head there, that as physiotherapists, we would never just prescribe one treatment or one treatment pathway or regime for any type of patient at all. But we were limited to what we had in our toolbox. Prone position, and we have for years as a profession been trying to advocate use of prone position and more, not just for oxygenation but for secretion clearance. There is obviously a resilience to do that because it is a safety issue. Generally patients are heavily sedated and paralysed because of tube safety. But the manual techniques, which a lot of my colleagues are calling old school. So you've got your old school techniques out and what you do. And actually we do kind of use these techniques still in everyday practice, particularly, for the rib springing, expiratory vibrations, manually assisted cough, not just with our neuro patients now, but, more so with COVID patients as well. And again, the installation of saline here has been crucial. And I don't know what your incidence of secondary pneumonic type infections are, bacterial infections for this patient group, but my experience has actually been quite low. I wonder if you have any comments on that.
I'm not sure I wouldn't want to speculate. I've certainly not seen a great deal, but I'm not sure.
The actual data isn't there, but it would be interesting to see, because a lot of the anxieties around using saline is because we introduce infection. So for me, it would be, if there's any clever people out there who are going to be looking into this, that would be a great correlation. So we've talked about things you can do. What about the things you can't do? You mentioned disconnection of the ventilator to use manual hyperinflation, which is, absolutely to protect our staff and protect the recruitment. Anything else that has been a kind of no-no?
I wouldn't say necessarily a no-no. Like I say, auscultation was one that we were stepped away from. I think early people were worried about touching stethoscopes, touching your face, wearing hoods, PPE, just not really making it possible. That initially for a lot of staff felt like we'd had our arms cut off, because it's obviously such a skill that we'd use so often with these patients. We did still use it on occasion when we needed to, but I think we got very good at assessing in different ways. One of the positives about the anesthetic vents, and I wouldn't say there's a lot of positives, but was actually the bags incorporated into the circuit. So if you did need to re-recruit or do something in an emergency, you could actually bag through the ventilator quite successfully. But certainly disconnection was difficult. I think repositioning with the more unstable patients, of which there were quite a lot, repositioning could be limited, and actually we're having to treat more patients in the position that they were in, because we knew as soon as you moved them, they took 2 hours to re-recover, and it wasn't anything that you could really manage. So again, just taking more and more tools out of our toolkit. And a lot of the challenges really in terms of things you can't do came a little bit later, in terms of when these patients were starting to wake up. So we obviously had the first couple of weeks of everyone. It was really difficult because we had 2 patients per bed space, which was one of the ways that we'd increased our capacity, which meant at any one time we could have 40, 50 patients even on a unit, proned, paralysed, sedated, poorly chests. But then after we got through the 3-week period, more patients were starting to wake up, come round, and we could start that rehabilitation process. But then we had the challenges of rehabilitating someone who's in a shared bed space with somebody next door who's potentially proned, paralysed. We did get screens, but actually there's hardly space to get a person in between the beds, let alone a screen. So that made things quite difficult. Normal things you do to reorientate patients, move them to a lighter bed space, get them awake, alert. Again, you just didn't have the capacity to be moving patients around. the personal contact of actually being able to hold somebody's hand, smile, facial gestures, and build that rapport with somebody. I think we still managed it to some extent despite the PPE, but normal things that you would be able to do as these patients are recovering were really, really quite challenging. And I think also in with the agitation we mentioned before, just really, really high rates of delirium, which we would expect perhaps with a long stay ICU population anyway, but add in the PPE and all the other things going on in the environment. So certain aspects of care that we just had to kind of make sacrifices for and just do the best we could in a very difficult situation.
Completely. And I think some of the challenges that we've seen across the intubated and non-intubated patients is this fatigue. So this real feeling of lethargy and extreme muscle wastage actually, and coupled with that, we've talked about in the other podcast about the higher BMI some of these patients had, so it was masking a lot of muscle wasting, and then the nutritional deficits on top of that. So in terms of the most complex of ITU patients we would normally see and rehabilitate, these are absolutely in that subgroup, aren't they? And not only that, there are multiple patients of that same phenotype in your intensive care unit at once. So talk us a little bit how you manage that, because you know, for what success is the wrong word here, but how you adapted your workforce, how you recognized and changed your everyday professional behaviors and to meet those demands. Tell us some of the things for people who are listening who could potentially adopt in their practice.
So we've obviously got quite a rehab active unit anyway, and I think we've got really established structure around how we deliver our early rehabilitation. One of the things we made a very early decision to do, so we've got electronic patient records, and physiotherapists hadn't moved on to electronic patient noting prior to this starting, but we made the decision to move our noting online onto the system because it was quicker to fill out, and perhaps got rid of some of the other documentation we would normally be using as standard. We suddenly didn't have the chairs and equipment available, so perhaps we had to modify the rehabilitation that we were delivering there. We still had the magic whiteboard. So one of the roles we took on as physio, I talked about task-based nursing before, we were actually given the task of managing the lung protective ventilation. So when new patients came in, we were measuring them, we were making sure they were hitting their target tidal volumes. And this meant there was a whiteboard in every bed space. So when they transmitted across, we could then document a specific rehabilitation plan and timetable for all of these patients. But it was heavy work. And even though we'd increased physio staffing, I think one day we notched up between 30 and 40 edge sits in one day. So a lot of patients, as you say, the majority, so 90% of them had a BMI above 25, 2 to 3 physios generally to get those people moving, but limiting how far you could then push and progress people. One of the interesting things we found, because the level of sedation, the prolonged periods of mechanical ventilation, the use of paralysis, I was expecting profound ICU-acquired weakness of a nature where patients would wake up unable to move anything. We didn't necessarily see that. So yes, 100% of them had ICU-acquired weakness, as would be described, but a lot of them could move. They had more muscle strength than we'd expect, and the primary limiting factor was actually the respiratory reserve. So when we got them moving, it was fatigue and respiration that was limiting their activity more than strength. And that fed in really with some of the weaning patients. We had a lot of patients who were weaning through pressure support, struggling with the step onto CPAP. And we started to notice that it didn't matter if you increase the oxygen, you increase the support, the respiratory rates were still running at the kind of mid to high 30s. And we very quickly at that point went towards a jump from pressure support to trachea mask with really good success. And we had some patients who were really struggling with weans that we put them on a trachea mask and they would go for hours on a first occasion very comfortably. So something about that respiratory deficit didn't seem to like the dead space in the tubing and the lower settings of ventilatory support. So working the wean in and around the rehab was really important.
Yeah, and you've touched on a good point there. So when in the MDT podcast, we talked a little bit about two phenotypes of patients who were sedated and paralyzed. You woke them up and you extubated them, and they were one set of patients. Then there were the patients that really struggled to wean, like you said, who maybe because of airway injury, airway pathology, you needed tracheostomies, and the data nationally just isn't there yet. But from speaking to people, we have again two sets of trachea patients: the ones that had their trachea and were weaned within say 3, 4, 5 days, just because they had a trachea, And then you have the other patients that probably still took a couple of weeks that you'd normally see your kind of tracheostomy weaning patient. It would
Yeah.
take that of time. So there's probably multifaceted reasons for that, with comorbidities and length of time before they presented unwell to need intubation, and the severity of their ARDS type picture. But in terms of how we manage them, so there's been lots of questions and lots of asks about how we manage them in the pre-extubation phase. So as a physio, kind of, if you think about those two phenotypes of patients, the ones who's on tracheed, who we wake and extubate, and then the trachea patients who we're weaning to decannulate. Do you have any pointers or experiences you can share?
I mean, it's a difficult one. I'd say one of the things we found with the extubations, for example, and I remember reading something from Italy that was saying, because I think we all did, you started reading the experience in other countries, and I think one of the things they were saying in Italy was that you almost had this second hit. So patients came in, particularly the younger ones, after a few days, seemed to stabilize, seemed to be doing a little bit better, and then either they were extubated and needed very quickly re-intubating, or they, as soon as you started trying to decrease support, they deteriorated. And I think that became very apparent with our population as well. Every time we tried something with less than kind of 7 to 10 days, it did not go well at all. So there seemed to be this period that patients needed. Now, after that, and I think linked to some of the sedation issues we had, it seemed to be that the decision to move towards extubation was quite a quick one, in that patients weren't waking particularly that well settled as perhaps we would normally on an intensive care. And there was a decision that they were making good progress from a respiratory point of view. Their chest was relatively clear. They were needing minimal support. The oxygen requirements were coming down. And then it would be a trial extubation, which on the most would work. I think the patients declared themselves as struggling quite quickly before we got to that stage. With the tracheostomy patients, as you say, there were a certain group where the trachea goes in and they almost ended up on trachea mask within a couple of days. And you think, perhaps did we need this, or it just gave us that bridge to get the patients more settled and more contained. The longer stay ones was then trying to go back to what would be a more normal kind of weaning pathway. So at that point, we started to create a section in our unit that was one patient per bed space. We actually had a small weaning area. We had joint physio and consultant ward rounds where we would set weaning plans. We'd get the OTs involved. Speech therapy were coming in. We'd start cuff deflations, giving people their voice back. So actually looking at a more normal pattern to the long stay patient recovery.
Yeah, and I think you've touched on the MDT there. Like I said, there's a whole MDT podcast, but what this pandemic has shown us more than ever is the added value and essential workforce that exists within an intensive care unit, and we can't do this in silos. And there's a lot of transferable skills across us all in how we can use this now moving forward. So moving forward is the kind of final section of what I wanted to talk to you about. So we are really hopeful that we've seen the peak in England, in the UK. We've seen this kind of disease at its worst, but there is a chance that there could be a second surge or a resurge. And now we have a little bit of time, we have a little bit of breathing space. Everyone's still incredibly busy, don't get us wrong. It's to now prepare potentially for what may come in a short period of time. There'll be lessons learned from this in a year's time, or whenever this is all over, as a country and as a respiratory community. But for now, what advice do you have about kind of this next phase of COVID?
I think we've learned a lot as a critical care community that perhaps we didn't know. I think there's still a lot that we don't know about these patients. The first big thing I'm saying to my staff is rest. And I think what we're seeing is that at our peak, including the non-COVID patients, we had 171 ventilated patients across critical care. And we didn't feel particularly tired at that time, but as the numbers are now coming down, I think it's starting to hit everybody. So I think there needs to be an element of take some time off, recover, rebuild your strength and your resilience for what might come next. I think the next thing it's really shown me is always plan 2 steps ahead of where you think you need to be. And thankfully we'd had that in place for the most part, but when things picked up, they picked up very, very quickly, and it was days, not weeks, that we had to prepare. I think, to make sure we've got all of our staff trained and experienced. But one of the big things that struck me, I think, when we first had the creation of the COVID intensive care, was we'd put the PPE on, go in, manage the patients. And as we started then orientating other staff, I think as a critical care physio, I perhaps didn't appreciate how daunting that was, not just to come in and treat the patients, but also the additional PPE. So I think getting people used to the donning, the doffing, the environment, the experience of what it's like just to be on there and trying to work in that kit is really, really important. And I think that can help to desensitize. But also, as you said, the multi-professional team. So I think we went at this very acute respiratory, and perhaps we overlooked some of the skilling up and getting the experience of the OTs much earlier. Speech therapy got involved a little bit later as well. So maybe having the MDT much more geared up and focused towards when this hits, how they're going to manage things.
Absolutely. And we're not talking specifically about the post ICU rehab and recovery phase of it. That's a separate podcast. But the identifying what the patients need is a huge part of this as well, and understanding what their needs are, because we just don't know. This is still so fresh. In terms of the workforce that you've just mentioned, I completely agree. And we have standards for intensive care. We have staffing recommendations for intensive care. Over the last 10 years, you know, people like yourself, many other leaders in this field have been trying to reach those standards to no avail. And I think this is now a time we recollect and say, what would have been the risk if you didn't have the physiotherapy consultant in that intensive care unit? What is the risk if you didn't have that consultant speech and language therapist in that unit? And really just understanding where that unmet need is now for individual intensive care units and moving forward. And really with some kind of courage and conviction, saying we have guidelines, we have standards that have been produced by multi-professional teams, and actually, do we need to go back and revisit those standards and have surge standards? And do we need to have normal everyday critical care standards? And I think for me that's a massive thing that as a profession we need to drive and work on. And again, you mentioned about planning the workforce, keeping people in the mix. There's going to be this grey area where staff start phasing back to what is their normal job. And we as managers and leaders, we're very mindful of that, aren't we, about the impact people might have for their well-being and their post-traumatic stress of coming into an intensive care environment, having never been in there before, having seen people die for the first time. That psychological burden is huge, and we do have a separate psychology podcast on that, but it's very much around being mindful as they may need to come back. We may need to bring them back into our intensive care units. So I don't know if there's anything else that you wanted to finish on, David. Anything that I might have missed?
No, I think you've kind of summed it up nicely there. I think it's a nice opportunity to speak on behalf of, I've got a fantastic team here that I work with. And I think we're very lucky that we've got a really good profile within critical care as a physiotherapy and AHP group. And I think one of the really positive things to come out of this whole pandemic is really highlighting the role of those AHPs in critical care, which I know in some trusts nationally is still a little bit overlooked. And I think it could really empower us to move forwards, get recognition for the work that everybody's doing nationally, and there's some great things that have been going on, and hopefully put us in a much better place moving forwards.
Absolutely, completely agree. Team effort, and particular thanks to you, David. As you can see, David's at work today. He's using his lunch break to talk to me. And David, you're amazing. I know you hate this kind of stuff, and it's actually took us about 3 or 4 weeks to get you on a video call. So thank you so much. Keep doing amazing work, and we look forward to hearing about any publications. I know you've been writing stuff up, collecting experiences. You're amazing. Thanks so much, and we'll speak to you soon.